The moderator of our first panel is Marilyn Serafini, a healthcare policy consultant and an award-winning journalist. Marilyn has been president and co-CEO, of the Alliance for Health Reform, now called the Alliance for Health Policy, a nonpartisan, nonprofit organization dedicated to helping policymakers understand the foundations of health policy. She covered Congress, the White House, and K Street for various publications, including Kaiser Health News and National Journal. And our panelists today are Dr. Ann Schuchat, the Principal Deputy Director for the Centers for Disease Control and Prevention, Seth Ginsberg, co-founder and president of Global Healthy Living Foundation, Gopal Khanna, Director of the Agency for Healthcare Research and Quality, or AHRQ, Dr. Lucinda Main, the Executive Vice President and CEO of the American Association of Colleges of Pharmacy. We also have former Congressman Patrick Kennedy, also a former Research America board member. Welcome. And we will be joined also by Governor Charlie Baker of Massachusetts, who will join the panel when he arrives. So Marilyn, over to you.
Great, thank you so much. And thank you everyone for being here for this important conversation, and especially to our experts on the panel today for being here. So we've just heard about a vision for a world without disease. So how do we get from here to there? How do we achieve that? We've talked a lot about cures, but we're going to spend some time during this panel talking about preventing and managing chronic disease and promoting better quality of life, and how we do that without feeding the opioid epidemic, which is on everybody's mind. So we're going to start right off by identifying some of today's greatest challenges, and I'm going to turn first to Dr. Schuchat with the CDC. So let's start by talking about a challenge that our new Surgeon General has identified as a top priority, and that's obesity, which of course feeds into diabetes, which of course feeds into other chronic conditions. So CDC data seems to indicate that we're not making a lot of progress in this area. Can you help us to understand the size and the scope of this problem and what the trend is?
Yeah, this is a tremendous problem. First of all, it's just a pleasure to get to be here again and to see all of you. Obesity is one of the toughest issues that we're facing. 1 out of 3 Americans is obese. Another 1 out of 3 is overweight. And both of those factors can lead to risk of many complex chronic diseases that shorten people's lives and reduce the quality of life that they have. We don't have perfect solutions for adult obesity right now. The most promising data we have is about preventing people from becoming obese, and particularly trying to tackle childhood obesity with really making a difference in the early years. There are lots of research projects ongoing right now to try to find solutions that will scale, but it turns out that reducing weight a little bit, not totally reversing obesity, but actually modest weight loss can really improve quality of life and reduce complications. We're focused right now on pre-diabetes. And again, 1 out of 3 Americans, or 84 million Americans, have pre-diabetes. And that's a condition that puts you at greater risk for type 2 diabetes and heart attack, stroke, blindness. We've issued a big campaign about 1.5 years ago that started. Go to doihaveprediabetes.org to see more about it, but it involves shameless exploitation of cute animals to try to help people figure out, am I one of those people who has enough risk factors that I need to attend to it? Obesity can seem hopeless, but as the Surgeon General has promoted, there are simple steps people can take to try to improve their quality of life, even if major weight loss doesn't occur. Control of blood pressure, improving physical activity, improving healthy diet, modest weight loss can make a huge difference.
Great. So there are other important trends in disease and chronic disease that the CDC is reporting on.
Yeah, the news for the past few decades, as you heard in the keynote, has really been good, with huge decreases in deaths from heart disease, stroke, and cancer. From 2000 to 2013, we had a 38% drop in deaths from stroke. But you may have seen yesterday we reported that has now reversed, and we are starting to see actually an increase in deaths from stroke. What we think is happening is the obesity epidemic, uncontrolled risk factors like hypertension are catching up with us. And while the incredible medical breakthroughs that many of your companies or your research groups have contributed to has led to better treatment of strokes and a reduction of death from strokes over the past few decades, now we're seeing a reversal. 3 out of 4 states have seen increases instead of decreases. So we have a lot more work to do, again, going back to controlling these terrible risk factors for chronic disease conditions and poor quality of life. The biggest thing, of course, that's going up that has all of our attentions is the opioid epidemic, and I know we're going to get into that in more detail.
Absolutely. Seth Ginsburg, at the Global Healthy Living Foundation, you seek to help patients better manage pain, everything from migraine to arthritis, osteoporosis. Talk a little bit about that. Help us to understand the scope of the pain problem.
Sure. So it's huge to very huge, unfortunately, here in the U.S., worldwide, actually. But according to the Institute of Medicine, for example, over 100 million Americans report pain, and that might be discrete pain caused, for example, postoperative or from malignancy. But it could also be the disease itself through headaches, right? And so are migraines. And as a result, the U.S. Spends over $500 billion a year in direct and indirect costs dealing with pain. And that is a number too large to fathom. And reason enough to focus as much effort and bandwidth as possible on the subject, as I know so many experts here do regularly, which is amazing. But as an organization representing folks whose pain ranges, again, from postoperative arthroplasty pain as a result of a joint replacement, or prior to that, from the osteoarthritis that led to the arthroplasty, to folks who have migraines, who 15, 16 million Americans are incapacitated due to migraines and headaches. I know this firsthand as the caregiver, as the spouse of somebody who literally, unfortunately, because the headache medicine was checked under the hold of a plane, which will never happen again, nearly needed to divert an airplane, as a result of an incredibly horrible migraine. And so as a result of that firsthand, but naturally, representing patients, throughout the U.S. living with this, the spectrum of pain, it's an issue we need to tackle and we need to address head on, so to speak.
Are we treating, and by the way, I can relate to your wife on the migraines, are we treating pain wrong?
I would say we're treating pain okay, and we need to treat pain much better. But instead of indicting the entire medical community for how we're treating pain, I'd prefer to look at the glass half full and look at all the opportunities we can, as a society, improve the treatment and the management of chronic pain.
Okay, great. So, Gopal, how do we leverage data and analytics to understand the trends in healthcare and some of these trends that we're hearing about?
Well, the keynote speaker did the job for me. He talked about data and the significance and importance of it. And we at ARC, one of the 3 core competencies is data, how we bring data together, harmonize it, leverage it, and do trends analysis. We've been doing that for a long time. And I'll give you an example. It was the analysis of the data we collect from the states that helped us identify the opioid problem a couple of years before anybody else even recognized how large and big that problem was. So data is extremely important, not just to track, but to identify and take a predictive approach so that solutions can be thought of from a policy point of view, as well as the point of care, and most importantly for research purposes as well. So the data is really the underlying infrastructure upon which research will be conducted going forward. Analytics will be done to identify challenges and problems and opportunities for solutions as well. So it has become an integral part, and it is a core competency that makes ARC distinct in the whole healthcare complex.
Can you take a minute to, I think most of our members of our audience are familiar with ARC, but I think it would be helpful to just take a minute to describe what ARC is, what ARC does, and how ARC is involved in this particular effort.
I think I'll go back again to our keynote speaker. He was talking about large, big disease eradication. We are the people at ARC who are the bridge between research and practice. We bring it to where the need is at the point of care, where the physicians are, primary physicians, clinicians are, and working with the patients. So that in a nutshell is what ARC all about. All the research must happen. We take all of that and make quality care happen, safe care happen, and evidence-based practices get put into place at the point of care, where the rubber meets the road, by the way.
Okay, great. So, Lucinda Main, we're going to turn now in full force to the opioid epidemic and talk about how how prevention and chronic care management intersects with the opioid epidemic and what's being done and to deal with this, or what kind of progress we're making. 91 Americans die every day from an opioid overdose, and healthcare costs for opioid substance use disorders exceed $26 billion with a B a year in direct costs. So with that in mind, how should we prioritize our research efforts to achieve the best return for the nation's health while also reducing costs?
It's a really important question. As I think about the opioid issue, every time I try to touch it, it just gets bigger and more complex. And I think that it is a great example of really great intentions, clinical intentions, regulatory intentions, resulting in unintended, unexpected, and really tragic consequences. And I really think there's two elements to addressing the crisis, and there's no simple answer because there's a lot of vectors in it. One is definitely research, and the other is education. And so on the research side, it goes everywhere from understanding pain better as a neurological phenomenon to finding some non-addictive strategies for addressing pain more effectively. From all the way to the other end, to your end, of really understanding the socioeconomic and behavioral issues that would help clinicians and regulators make better choices at the individual patient level and at the population level. And from the regulatory science perspective, you just have to think about what's happening across America when the regulators, with every good intention, have limited access to the opioids as safe, when used properly, regulated drugs. And what happens? Heroin and fentanyl become the leading cause of death in this. And so we have to have more data. We have to have greater insights into genetics to understand when genetics begins to influence the use of these products and their addictive qualities. And there's so much we don't know that goes over into the education, which I think we can come back to later. But across the board, there is just a real lack of sufficient education for clinicians and patients and everybody else in the ecosystem at this point in time.
So I feel super confident that the rest of our panelists want to weigh in on this, but hold on just for a minute because I want to turn to Congressman Kennedy to talk about what you see as the needs for both research and action and answers. Congressman Kennedy is serving on the White House Opioid Task Force along with Governor Baker. And I'd like you to tell us what's going on, where we are, and then I think everyone's going to want to weigh in.
Thank you. Well, I'll speak for Governor Baker as well, since I'm originally from Massachusetts, and now I can take up both of the time for him and I both combined. But it's great to see my former colleagues, Mike Castle and Bart Gordon, great friend, and of course John Porter, our great champion for research in this town, and thank you, Mary, for inviting me. So I am an opioid addict. I'm in recovery, 6.5 years as of just recently, and so I used to take Suboxone in order to be able to cope with the opioid addiction while serving in Congress. I used to also choose to go on what they were called drug holidays. And that is because I had to take the drug just daily, I could choose not to take it. And I say that because one of the big knocks against medication-assisted treatment, which is the evidence form of care for this opioid crisis, is the stigma against medication-assisted treatment, because there is so much diversion of Suboxone. So where are we right now? We have soon to speak the FDA commissioner who's promised to make this his #1 priority. He could literally expedite 2 different forms of medication that would transform the treatment of medication-assisted treatment and absolutely end diversion, because they're long-acting buprenorphine. One's a week, one's a month. They are able to intermingled based upon the personalized medicine of the person with addiction, because the person with addiction, we're not all the same. Like any other illness, there are different stratification of people with addiction. And that ought to happen tomorrow, given the number of people dying every day. And we're going to make that recommendation in the President's report. No reason to hold back anymore. All the due diligence has been done by FDA. The only thing is the protracted, dot the I's, cross the T's. All the trials have been done. Secondarily, to the question of pain management, so I'm now sober, let's say 4 years. I try to catch a falling ping pong table. I don't recommend anybody trying to do that. It nearly took the top of one of my fingers off. I had to go to the ER. I told the doctors that I was allergic to penicillin and opioids. They hadn't heard that before. It was like, what? Allergic to opioids? They didn't know you could be allergic to opioids. That's part of the medical culture that also has to change. But my point is, that's all they had to treat me, in their mind. Now, if I had to risk whether there would be side effects to a non-opioid pain reliever versus an opioid pain reliever, I would say to the commissioner, I'll take my chances with the side effects for this other option other than the opioid, even if it has potential real detrimental side effects, because against me getting addicted to again, I'll take that. Right now, there aren't adequate number of drugs in the pipeline to treat those who have the high risk. And by the way, we don't need to know the genetics. All you need to know is a family history, but God forbid a physician ever asks for a family history of addiction when you go to the physician. And I mean any doctor. We're not talking primary care. Orthopedists ought to be top on the line, but it ought to go right down the list to geriatricians, pediatricians, everybody ought to be able to triage their patients for addiction, because at some point or another, they're going to need to know that if they're going to adequately treat their patient. And so you'll hear from Governor Baker, if he gets the chance to say it, that this whole system of medical education needs to be changed top to bottom in response to this crisis.
Okay, so at this point, we heard about changes at the FDA. We heard about getting adequate drugs into the pipeline. I think there may also be an insurance question, a coverage question in there. So I'd love to hear from other panelists about, we're now well into what we need to do about this and how we approach this. So I'd love to hear from some of you about, in response to the Congressman's comments, and also if there are other areas we need to touch on.
Yeah, I'd like to sort of follow up on the practice issue. When you look at opioid prescribing in America, it's really shocking. We have a 6-fold variation from high prescribing counties to low prescribing counties. And even though we've had a decrease in prescribing since 2010 in America, our rates are 3-fold higher than Europe. Not to blame anybody, we got into this with good intentions, but clinicians like me were taught that you can't get addicted to these medicines if you're really in pain. And we thought they were safe and effective, It turns out for a lot of types of pain, opioids are not effective for chronic long-term pain of many types, as you were describing, and they have tremendous harms, and you cannot always anticipate who they're going to have the harm in. So the young athlete, high school football player who injures their back and gets started on something is just as likely to become addicted as that person that you're really expecting to become addicted. So as clinicians, we have to do better. In March 2016, CDC issued a guideline for prescribing for chronic pain that was really about think twice before you start one of these medicines. If you do start people on opioids, have a plan, follow up actively, start slow, start low dose and go slow in increasing it. So it's gonna take us a long time to deal with all the people who are already addicted, but we really need to prevent more people from becoming addicted by improving prescribing.
So I want to go to Dr. Main in a minute, but first I want to ask you, Dr. Schuchat, what was the effect of those recommendations? Did it make any meaningful impact?
You know, we've had a huge response to the guideline. We have actually started to see some decreases in some health plans, but we've seen medical schools, residency training, nursing schools, pharmacy schools adopt them into their core curriculum. And it's, you know, just the beginning. We have a lot of tools that are going to make them easier to implement, you know, checklists and apps and things that can be baked into the medical record. But there's a huge culture of medical practice that has to change. That six-fold variation in geography tells us that there's hot spots that we really need to work on, and having better data about where the morbidity is and the mortality, as well as the prescribing, can help us and help the states really focus in on the areas that have the greatest need.
Dr. Main, I know Governor Baker is going to weigh in on this, but I'm not sure we can dance around the education issue. He'll weigh in when he gets here, but
I actually had a medical education colleague recently admit that there's approximately 1 hour on addiction in the classic medical education curriculum. I can't tell you what the analogous number is. I should be able to tell you what it is in pharmacy. I know it's bigger than an hour. I also wanted to mention that there have been some structural issues associated with the insurance enterprise that I know there are very important dialogues going on right now. Some of this is influenced by other federal regulation like the DEA, and we really need to invite them into the conversation about these controlled substances and how they should be managed. Things like partial fill, so that I don't go home from a simple tooth extraction, you know, with 30, 60, 90 pain pills of any kind, when there's a good chance that I might need two. But there's, you know, there are some things about insurance and the copay and things that can easily be addressed once we have all of those issues on the table.
There's another issue here, and that is the lack of interest amongst any of the medical professions to actually become a medication-assisted treatment provider. The docs got us into this mess in the first place, and yet they're refusing to get us out of it. What the AMA ought to have a moral responsibility to ask all of their members to write for medication-assisted treatment. Right now, less than 10% of the providers in this country write for medication-assisted treatment, even though Nora Volkow from NIDA and all of the other experts, ASAM, said this is the gold standard for care. Can you imagine only 10% of the physicians in this country adhering to the gold standard of care with the size of this epidemic the way it is?
why? Why are we not
Because they want to treat addicts. We're not a popular bunch. We're not a very sympathetic crowd. People usually don't like us, especially when we're active in our illness.
Does it have to do with reimbursement? They simply don't get, it takes a lot of time?
Well, reimbursement's another issue, and it's a function of politics. No one advocates for this crowd, and hence we underpay. I'm going to go see Mark McClellan's former colleagues over at CMS tomorrow, and I'm going to read them the Riot Act, because I want to ask how many in that room have suffered from addiction. I guarantee hardly anyone are going to put their hands up. I'll check. Maybe you can give them a little heads up. I'm coming to ask them that. And then I'm going to ask them, how many of them believe this is a real disease? And of course, they're all going to put their hands up because they all want to look enlightened. And I said, well, if it is a real disease, why aren't you paying for it like any other medical disease? Because The reimbursement for substance use disorder is criminally low. It's criminally low. You would not allow this to take place if it were any other illness, period. And yet CMS doesn't reimburse for it. Why should any of the other big insurers reimburse for it? They take their message from CMS. So we have big problems, big time.
What specifically are you going to ask them to do to change this problem?
Well, I've got very specific recommendations for them to beef up, bump up codes, particularly the collaborative care, coordinated care codes. Going to tell them they got to reimburse for all RAIS, which is early schizophrenia episodes. They ought to be paying for that now. I'm just going to tell them all of their value will show that this makes economic sense for them to treat people, especially with Hep C growing at record amount right now. You know, it's costs over $30,000 to $40,000 to treat Hep C, not even a perfect cure. And the skyrocketing rate of Hep C means it's going to dwarf the cost of treating people with addiction in this country. When you've got 45,000 cases of Hep C at 30,000 a pop. All I'm saying is, like, we need to get out of denial. We are in collective denial as a country. The only reason we're paying attention to hurricanes is because they're on TV all the time. We see the images. We go, oh, my God, this is horrible. If we saw those images every single day of people getting crated out of, you know, West Virginia or New Jersey or any other state, people would be horrified. They'd be saying, what are we doing about this problem? But we got the eye shades on because no one likes this crowd. No, it's, you know, and here we are. And it's going to get worse. It's going to get worse. And if we don't get all hands on deck and get our docs out there, we're going to be in real trouble. And right now, hardly any docs are signing up to treat the people with this, you know, illness.
Yeah, I was just going to say, I think I don't really want to argue with you, but just.
But she's going to.
But why not, right? Okay. So I actually think as a nation, we're beyond denial now. I mean, the places that I visit, state after state, recognizes this is in so many communities and so many families. Everybody knows somebody who's been affected. I just got back from Vietnam, where we had a demonstration of what they're doing about the addiction problem, and they talked about it used to be called a social evil, and people were incarcerated, and we saw this, you know, room full of young people training to be addiction counselors, and medication-assisted treatment is entering their lingo. I think in America, politically, socially, economically, people recognize this is a catastrophe, and we have to do more. CDC is funding 44 states to improve their prevention programs, to strengthen the prescription drug monitoring modules, you know, so that docs could know if a person got 3 or 4 other prescriptions right before they were entering a new prescription. They're tracking hotspots so that they can get there for whatever the latest fentanyl equivalent is that's on the streets. We're working closely with public safety, with DEA, with DOJ to address the high incidence drug trafficking areas. I just think this is touching too many families for us to be in denial. So I don't want to argue, but I think we have a turning point.
The bottom line is 2 weeks, we lost 45 tragic deaths due to Harvey. How many opioid deaths in 2 weeks? At twice that a day. And we just appropriated first tranche $7.5 billion. And yet, for the best we can do in Congress is $500 million a year, and that took a lot of bargaining. And I guarantee you with the other supplementals coming up, we're not going to have any problem appropriating $100+ billion, which is what they're calling for Harvey. And I'm just saying, you know, you make the case. This issue's not getting the attention that a true emergency requires.
Yeah, one of the women that I met in Kentucky, which has been like the hardest hit state of the epidemic, described that in her community, what she said was, we've been admiring the problem too long. You know, we've been talking about it, we've been admiring it, and we really need to do something. So perhaps I'm not arguing with you.
No. If you were in charge, I'd be all right.
So where are we on?
Somebody write that down.
And
ahead.
on that positive note, I must admit, Congressman, that ARC, the Agency for Healthcare Research and Quality, in our humble little way, have recognized and working with our agencies to identify that we need MAT. So we are working 4 states to identify how we can do medicine-assisted treatment so that we can figure out what might be the best way to make that happen in rural America, because a lot of people think that it might be an East Coast or a West Coast problem, but actually opioid is agnostic to race, age, income levels, and location. And we have to think about even the mid-America and the rural areas where, and figure out how we're going to make that happen. So you're right, and then we need to do that.
So specifically, DEA should not be breathing down these doctors' backs. After all this crisis, we're jumping on them, and now why do they want to bring up any opioid treatment strategy? They're all scared to death of it. And so unwittingly, in the effort to clamp down on opioids, we're clamping down on the opioid replacement therapy that is the evidence base to treat the crisis that the docs got us in the first place. So who's going to actually train to do medication-assisted treatment when they got DE branding down their back and they don't get paid for it? Ding, ding, ding. No one wants that. Don't like to treat the patient, don't get reimbursed, and they got DEA down their back. Period. 3. Strike out. So all I'd say is, if you had real political will, you'd say enough of this. Enough of this. Get everybody out there prescribing, save lives. People are on fentanyl now. It's going to take so much to get them off fentanyl. We need, Commissioner Gottlieb to get going on releasing these new medications. And we need to get alternatives for other pain other than these opiates in the first place.
So how much of this is education and the medical professionals, everybody from the physicians to the pharmacists to anybody who's involved in this, not having the education and not perhaps knowing what to do, and how much of it is the money, the reimbursements? We also talked about funding, which I think we were talking about something a little bit different there, and I want to get to that in a minute, but how much of it is the education versus the reimbursement? It's not, they can't make it work with the time that's involved.
I think we have to resist the urge to oversimplify, and that this is a really complex epidemic. There's a culture change that we need. There are lots of structural barriers that we've been hearing about with insurance and payment and, those kinds of barriers. But there's a huge issue for clinical practitioners in terms of their culture change, and a huge issue for consumers or the public as well. At CDC, we think about this similar to antimicrobial resistance, where we used to think antibiotics were like miracle drugs, lifesavers, no harm, just try it. You don't want someone to, die of an infectious disease because you didn't start antibiotics. Now we realize, well, wait a minute, there's times where we've just been overdoing it and we're seeing the complications now. So we think the public really has thought, a little pain med, I got it from my dentist, I'm keeping it, I'm using it for something else, in some people can lead to long-term addiction. So, in addition to this big challenge of educating or changing the practice of physicians, we also need to change that culture of consumers to, now I know lots of people ask their doc, like, I don't know, do I need an antibiotic? I'm a little worried about that. To get that same idea about pain control. I think I'm okay from the dentist. I don't want that. Or can I just have a small prescription instead of a larger one? So again, we're trying to get, a PSA campaign going that'll be launching later this month to really have that prescription medication culture change. Lots more to do on illicit drugs, but since so many people, I think it's 2 out of 3 right now who end up on heroin started with prescription opioids. So we think that, I wouldn't say education or insurance, that we really need to tackle this on every front.
We had the opportunity to talk with Secretary Price last month, and this was the focus of the conversation. And I used the term, it feels like a whack-a-mole situation where, okay, it's education, we're going to get that. It's regulation, it's all of the above. I have thought that it would be very useful if all of the principals had sort of a map from causation, through treatment, appropriate treatment with prevention in the middle. And we could really systematically determine where the most important touch points are. It is absolutely core to health professions education today, as it has probably not ever been in the past. We have students who are going out working on drug take-back initiatives, and into the elementary schools and the high schools doing drug prevention, and so it is on everybody's radar screen. But I think we feel a little bit inept in getting to some of the root causes of the problem so that we can get to solutions without causing other unintended consequences. And that's the really frustrating thing, is that if it's not going to be opioid, it's heroin with fentanyl and carfentanil. And that's actually probably more responsible for the death experience right now than the prescription opioids.
And what about the role of pharmacists? What can pharmacists currently do? And what do we need for them to be able to do? Do we need for them to take a greater role in figuring, determining where there are problems, and what should their role be, and what is it currently?
They certainly are a conduit to both the problem and getting these medications out of the control system of a pharmacy out into the community where we know they get diverted. I actually had a person who manages our health exercise fitness place bring me a bag of OxyContin and related products that she had stored in her home over multiple years. Why? She didn't know if she would ever need them again, and she didn't know how to get rid of them. So pharmacists can be really important agents in helping ensure the public understands what to do when you don't need 43 of the 45 capsules that you get. They can be very important in terms of health professions, colleague education, and team-based care. And just yesterday, a conversation about the inadequate ability of clinicians writ large to manage pain. This was in the context of veterans' health, and the fact that we really needed to gin up more pain specialists and make them available for some of the more difficult, retractable pain situations. So there are a lot of opportunities for pharmacists to have their role to play in this larger system, but it's in collaboration with everybody else in the ecosystem.
So we already heard that the physicians are not getting, and the other practitioners are not getting reimbursed properly, so they're not getting into this. What about the pharmacists? I mean, every time I get my prescription filled, they're just like boom, boom, boom. They can't count the pills fast enough and get on to the next.
Mary, can we have another 45 minutes? No, there's no question that there are issues associated with the distribution of medications today and how they are being reimbursed 95+% by third-party public and private payers that are paying modestly for distribution and not adequately for education, for monitoring, and for the kinds of services that could be available in the most accessible outlets of care across the United States, which are community pharmacies.
Okay. So, Congressman Kennedy, I want to get back to you because you ticked off a number of, you've got a full agenda. You're going to CMS tomorrow. You said you believe that a lot needs to happen at FDA, and I was wondering if you could expand on that in terms of what you think FDA needs to be doing differently and how it can do that, how we can get there.
Well, going back, everyone's recited that this is going to require a comprehensive approach. And that's what I heard just this morning when people were talking about FEMA. It was enacted because we needed a comprehensive approach to get our arms around any natural disaster. You needed housing involved. You needed to involve the schools. You needed to involve, employment. You needed to involve commerce. You needed to involve, healthcare. It was like, and then when you think about this opioid crisis, you need to involve literally every facet of the government, and you need to have a strategic plan. But you start by putting out the fire. You don't start monkeying around with, let's put the plan together, and we need a comprehensive, and this needs to include this and that. Hey, Governor.
And we have Governor Baker here. Welcome.
And that's what's been missing, because people with addiction need supportive housing. They need supportive communities. They need, this medication-assisted treatment. They need access to inpatient treatment where necessary. I mean, they need a whole array of things, and that's what ideally the commission that the governor and I serve on is going to recommend, and hopefully the administration is going to follow. But the immediacy is, if you're requiring docs to get 8 hours more treatment to do medication-assisted treatment than to prescribe opioids, hello, you got a problem, okay? You want to know if this is an emergency? Get rid of the additional hours required, okay? Do continuing education, make it easy, because like I said, that's a barrier. Reimbursement is a barrier. And DEA, barrier. Collaborative care, barrier. But let's just start acting. We don't have to go search this stuff. Former Surgeon General's reports lay it all out. This is not new. We need political will, not a whole lot more talking about this, in my view, because we know what we need to do. We just haven't gotten around to giving it the political will to get it done.
Fantastic. Governor Baker, welcome. Glad you could join us. We have been talking about chronic conditions, prevention, and how that all ties into the opioid crisis. And you are, like Congressman Kennedy, you serve on the White House Task Force on Opioids. And I'd love to hear what you really see as your top priority, the top priorities of that task force, and what you are doing personally with the task force and otherwise to where you see your top priorities.
Well, first of all, I'm really thrilled you're all here to talk about this, because one of the big things I learned when I was campaigning for governor in 2013 and 2014 is most people really didn't want to talk much about this. And almost every conversation I had with people early on happened when somebody came up to me after the event was over and said, "You're a healthcare guy, right?" And I said, "Yeah, I spent most of my career there." And they said, "Well, I got this friend." And then they tell me a story about somebody who is dealing with addiction. And I literally heard it almost everywhere I went. And my wife, who is also out campaigning and much better at it than me, would come home and say the same thing. And we started to wonder if we were just listening for this, if there was something big going on. So I did what I usually do in those situations. I went and visited with a bunch of docs and care providers I knew who worked in emergency rooms, and I went and spent some time with some EMTs and some first responders. And I said, "I'm hearing this opioid thing kind of everywhere I go, but I'm not sure if I'm just hearing it because I'm listening for it or if there's something big going on here." And to a person, they said, "Yeah." And then they used, avalanche, catastrophe, calamity, whatever word you like. And then I had my folks on the team go do a little research, and this is still campaign season. And they came back, just dug around in the data and came back and said what I think a lot of people in the space already knew, which is that there was a gigantic crisis going on here, and it was completely off the radar. And when I talked to some of the folks in the ERs, and I said, "You guys all know me. I mean, I've known you for years, and how come I had to go talk to you about this to find out about it and bring it up? How come you just didn't tell me?" And they said, "Well, I'm busy. I'm just doing my job, and I'm not really paying that much attention to sort of higher order issues." And one of the things we tried to do with our task force and with our legislation, which I'll bore you with if you're interested in, was to elevate the conversation around this. We've done public service campaigns and straight out media campaigns on stigma, and we've done a lot of work to expand our treatment and recovery capacity. We've increased it by almost 50%, and the last waiver we got from the federal government for our Medicaid program dramatically expands our mental health and addiction coverage capability. And we're the only state in the country where you can't graduate from medical school, dental school, nursing school, or pharmacy school without taking and passing a course in opioid therapy and pain management. And we're the only state in the country where if you're a licensed prescriber, when you go back to get your license renewed, you're going to have to take and pass a course in opioid therapy and pain management. Because one of the most unbelievable elements of this whole issue for me has been how undereducated and underinformed the folks on the front end who do a lot of the prescribing are and continue to be. And the fact that the pain community and the addiction community have never really had any ongoing serious conversations with one another about the role they both play in all this is bizarre. There needs to be more of that. But my view is take as much of what we've done that I've seen work in Massachusetts and as much of what we've seen that's worked in other states on this stuff and get it into the national conversation and make it part of a national platform. And the other thing I'd say, and this is the point I really wanted to make here today, we have not done anywhere near as much investigatory research around what works in addiction as we have in so many other areas. And I would love to see the feds get as serious about this issue with respect to research and protocols and best practices and all the rest as the feds are in so many other areas. If we think this is a crisis, we think this is an epidemic, well, then gosh darn it, the feds ought to be stepping up and playing a much bigger role in helping people understand what works and what doesn't and why. And doing the kind of work that's made so much progress in so many other fields.
So I want to ask the panel to expand on that as to where the research needs to be and what kind of funding we need and through what channels. But before we do that, Governor, I want to ask you specifically about Medicaid and specifically the challenges with opioid addiction for the Medicaid population. And are there opportunities to work through the Medicaid program to deal with this issue?
Well, certainly the waiver, the 1115 waiver that we got approved about a year ago, significantly expanded our mental health and our addiction coverage. And that was for a reason, because we were well aware of the fact that this is a huge issue for people who are served by that program. But I also think it was a big message that we sent to the provider community and others that this was an area we wanted to invest in, and we wanted them to help us figure out how to do it and how to be smarter about it. But I'm one of these people who thinks that, you can't think about this just in terms of treatment and recovery. You have to think about it in terms of prevention and education. Frankly, I'm a healthcare guy, but the healthcare community created this crisis in this country, because they got extraordinarily casual about something that they weren't so casual about 20 years ago. And you can't write 80% of the world's opioids when you represent 5% of the world's population and not expect that there will be consequences to that. And truthfully, there was a lot of information out there for a long time. If people had been able to stitch it all together, that would have started telling people that there was something really big going on. And for one reason or another, it just didn't find its way into the public bloodstream until we were way down the road. So we're going to do a whole bunch of things on the treatment and recovery side, but we have got to be focused on the prevention and education side of this thing, or we're simply never going to get where we need to go.
Okay, so let's talk about research and what we need to be focusing on in the way of research in this area. And after we do that, we're going to open it up to some questions from the audience. So go ahead and get your questions ready. And in the meantime, where should we be focused?
I'll go.
Go ahead.
Full disclosure, first of all, I'm a co-principal investigator of a patient-powered research network funded by PCORI. Arthritis Power collects patient-reported outcomes from people living with all forms of rheumatic diseases. And to us, PRO, patient-reported outcomes, is the fulcrum of addressing so many of these issues long before they become the problem that we've been discussing today. All right, we're talking about 15, 16 million people with migraines, right? How do you measure a migraine? How do you compare one's pain to another? I could tell you right now, my wife's threshold for pain is an order of magnitude greater than mine. And yet, we would still be classified as the same patient technically, and same with, rheumatic disease pain and so forth. So in our view, the emphasis can be placed on patient-reported outcomes for so many of these conditions, because I really appreciate the conversation here and the dialogue and the important work that everybody is doing collectively to address the epidemic of opioid addiction. But I don't want it to come at the risk or the cost of eclipsing the genuine and incredible pain, literally, that millions of Americans are living with. we can do better. We can do both. We can help the people in pain, and we can prevent the people from getting addicted. And I just want to make sure we're addressing both sides of the ledger. And we believe that patient-reported outcomes could technically sit as a fulcrum between those sides.
How much conversation between the pain community and the addiction community takes place?
Not nearly as much as there
Yeah,
should be.
that's what I
Pain
think,
Week is
too.
coming up next week, I think, in Las Vegas. And no, I think that we have a lot more. And again, it gets back to the difficulty in quantifying pain. How do you quantify a migraine? How do you quantify pain associated with a malignancy? You can't. You could look at radiographic evidence or bone-on-bone joint degeneration. You could say, yeah, that's probably pretty painful. But or someone with a spinal cord injury, but you can't of so many of these other syndromes. And so the challenge there is quantifying and clarifying and specifying what that means. And I think the word we all should leave here thinking about when it comes to addressing so many of these issues is technology. Literally, technology. How can tech address so many of these issues? Because today we are finally at that intersection of medicine, science, communication, and technology, and we were never there 20, 30, 50 years ago. And so going forward, how can tech serve as the pivot point for so many of these challenges?
How can it, panelists?
I was going to go in a different direction.
So let me just make a point about technology and this specific crisis in a conversation that a colleague had with someone from Sweden. They were comparing the use of opioids in their country versus here. And as you alluded to, the comparison is crazy. They said, well, we eliminated our opioid misuse problem by requiring electronic prescribing of every prescription. How does that relate to research? As I sit here and think about what we've learned in our country, yep, again, we could squeeze down and optimize the appropriate prescribing of a very challenging and difficult to manage substance that does address some pain well. But what don't we know about the unintended consequences of making that portal very narrow? And are we then, igniting the other related crisis of illicit drug use and addiction? So there are no simple answers, obviously, to the question, and there are researchable questions that are fundamental to our progress across the entire spectrum of research.
Okay, we're going to turn to Dr. Schuchat and then to questions. We're going to have 2 roving mics. So if you have a question, you can already raise your hand and a mic will start to come to you. Okay.
Yeah, I just wanted to kind of build on the issue of measurement. And, I'm a measurement data kind of person. But one of the ways we got into this problem was a measurement issue where in quality of care in hospitals, people were asked about that 5th vital sign, are you in pain and how much? And we got into a vicious cycle of over-treating a quantitative, self-estimate of pain that probably worsened the over-prescribing that we had. But measurement is really important going forward, and we had this plea for the holistic nature of the problem and the holistic nature of the solutions as we've been working across government in some of these research evaluations of medication-assisted therapy and what works and what doesn't in cohorts. We've realized that we can't just be looking at health outcomes. We can't just be looking at overdose and hospitalizations. We need to be looking at, return to work, family crises, issues of stability, and really understanding the bigger picture so that we don't go down a road of more unintended consequences.
And my point of tech, is at least we have the computing power today to do that. At least big data is a reality that we can input all of these domains to begin to understand this.
And I'm just sort of saying that it's not just the health data that we need to be looking at.
Actually, there's a lot more data, and the volume, the variety and velocity with which data is hitting us creates both challenges as well as huge opportunities to have a deeper understanding for solutions. And from ARC's perspective, talking about research, there's a dimension that we cannot forget, which is applied research, so that we can bring all the solutions that have been talked about, math, etc., and deliver it at the point of care. And the faster we can do that, the better our solutions would be.
I'm wondering on the data, do we really have the accurate data on the number of people dying from this
Yeah, so
crisis?
thank you. We don't, but we're making progress. So CDC's Vital Statistics Program tracks deaths, and those come from medical examiners and coroners. There's a lot of missing data. There's a lot of slow data. Lots of times unknown cause is probably overdose. Lots of the overdoses, we don't know what the overdose is due to. Delays in toxicology testing. One of the big secrets that is out there is how fragile our medical examiner and coroner system is in this country. CDC's started to issue a monthly report, so instead of having 3 years old data, we only have 8 months old data. But we just reported, the 2016 data, which is unfortunately 64,000 deaths due to drug overdoses in 2016, a 21% increase from the year before.
But just for everyone's, you check out at CVS, you have it barcoded. They know what you bought and when you bought it. The notion that we have to wait 8 months while we're having a pandemic across this country in this day and age, I mean, does anyone strike you, doesn't that strike you as odd that it would take that long? And that we would be relying on all these elected coroners. I mean, a lot of this country elects the person that decides what your death certificate looks like. I'm not kidding you. So we don't have a real handle on the size and scope is my point. And I thank you for a doctor for confirming.
All right, thank you. So let's go to our first question right here.
Yeah,
If you could identify yourself, please.
sure. This is Victor. I should stand up. Okay. This is Victor Zhao from the National Academy of Medicine. Thank you very much for this great discussion. You emphasize research education, but I haven't heard anything about educating the younger people who actually are the ones who are more prone to addiction, nor the research in biology of pain and biology addiction. That's where I believe where the investment should be. Because once you have a much better handle of different types of pain, and also the biology of the addiction, as you see. For example, if you look at the age-dependent addiction, last Surgeon General told me that when he looked at the data, if 13-year-olds exposed to an opioid, 75% chance of being addicted, whereas if you are about 20 years old, the number drops to about 25%, right? So there's a really an important biology and also education in that particular population. The other thing that we didn't discuss or somebody touched on are the social issues, the root cause issues. We can blame all the medical profession, but we're dealing with a fundamental issue in this country with some social, economic determinants, which makes people more prone to seeking out these things. So I would appreciate someone talk about those.
I just would like to add one little clarification that I used to think that it's a young people problem, opioid crisis, but actually our data shows that it really is age agnostic. We have young people problem, we've got middle-aged problem, and we've got aging population problem when it comes to addiction. And actually one thing I thought was that it's more likely men problem. It is really not. Women have caught up, and they're now equal to the number of men addicted to opioids. And this crisis has many dimensions and nuances to it. Sure. So I just want to be sure that we realize that it's...
Excellent. I think, Victor, the point about how we could do an opioid recommendation and neglect the fact that we have a suicide crisis as well is a terrific point, and that this is indicative of a broader systemic challenge. And hopefully in our commission report, whatever we recommend for the opioid challenge could also be helpful in impacting the terrible rise in suicides.
Paul, I realize that any age group will be, prone to addiction. But I think the biology shows you that you're more prone to addiction when you're younger. And if you look at the surge, they affect more of the people in the teens to the 30s. So I just want to point that out as a fundamental issue, a crisis.
I understand.
One of the things we did was, in Massachusetts, if you play a sport at the middle school or the high school level, you have to participate in a pre-meeting before the season begins. It involves your parents, your coaches, and somebody from the medical community. And it was always set up as sort of a health and safety conversation about hydration and concussions and stuff like that. Well, opioids are now part of that conversation because the more we can do to make sure people early on, not just the kids, but the parents and the coaches and the folks in the schools know about this and talk about it, the less likely we are that somebody's going to get surprised by some of the downside consequences of this stuff. I also think I'm not kidding when I say I'm glad you're having this conversation. Huge part of why this became the kind of issue it became, in my opinion, was because no one would talk about it. I can't tell you how many parents I've talked to over the past few years who said, I never told my neighbors, I never told my friends, I never told anybody what killed my son or killed my daughter because I was embarrassed. And the more we can do to get people to the point where they're willing to speak openly about this, the faster we're going to be able to get people to get serious about spreading the word and engaging in the conversation about the prevention and the education stuff on the front end, and the fact that there are treatment methodologies that can work for people, and for folks not to literally shy away from this in a way that has just been extraordinary for me to watch. I mean, people love to talk about illness, but they don't love to talk about addiction. And it's a big problem. So the fact that you're here talking about it and the fact that the issue is being raised is good. That we should do more of this.
Thank you.
Just if I could, one last, because this is another elephant in the room down the road, is marijuana. So we've got inundated at the commission by people proposing that all we do is expand marijuana availability in order to deal with the opioid crisis as kind of a substitution drug. But to your point, Victor, you know, the exposure of marijuana on the young brain, to your point, whether it's opioids, marijuana, or alcohol, it's the judgment of Nora Volkow at NIDA that puts you at extreme risk for later addiction. And I only wanted to use that as an opportunity to throw that in the mix.
Thank you. I think we could talk about this for hours and hours, but unfortunately we only have time for one more question, and here it is.
Thank you. Jay Gershon, I have the pleasure of serving as president of Northeast Ohio Medical University. And I also have the pleasure of serving on the board of the Ohio Chamber of Commerce. And last week I was at a board meeting, and they had just completed a survey of the state's businesses. And not shockingly, the number one problem that businesses are having are people not passing the drug test. Right. And therefore there's economic impact to these businesses. They can't find enough employees because there's not enough people who are drug-free. So getting back to the Congressman's point about $100 billion versus $500 million, how can we leverage the business community to begin to take this on from a national policy perspective to make it more impactful and to get more of a multiplier effect?
I just want to say one thing. I think the business community is a key issue. I think the Department of Defense as well, if you look at how you can fill the ranks of what you need to fill. So our nation's defense is really threatened by this epidemic. So I think your points are fantastic.
And the business community needs to be acutely sensitive, not just to the opioid addiction issue, but again, to the precursor to it, to the absenteeism, presenteeism issue with pain, chronic pain, migraines, and so forth, so that they can address that within the ecosystems of their companies as well.
This is an opportunity for Tom Donahue and Rich Trumka to come together. I mean, this is Janet Yellen said it, and listen to you, Jay, so you're in good company. The Fed said this is a drag on our economy. It is. The president cannot initiate his whole infrastructure bill if he repatriates those hundreds of billions of dollars in overseas corporate profits. There's nothing to pay for. We can't get enough workers. Walmart can't open enough stores. There are not enough workers to build them. I mean, this is like a real crisis. Why business has not come out like in a stronger way, to your point, Jay, is pretty shocking. Thank you for bringing that up.
I may bring that up with some of the ones in Massachusetts and see what they say.
There you go. So please join me in thanking this panel for addressing this very tough issue, not only today, but every day. And with that, I'm going to turn it back over to Mary to give us instructions moving forward.